Well, thank you, Dr. Chow, for allowing me to present here. It's very exciting. So today's talk is about Diastology, and I sort of titled it Relaxing Journey Through Diastology. So as a pun, because it's about ventricular relaxation, I would say that trying to learn the Diastology for the first time wasn't super relaxing, but hopefully we can make it work together and it will be as relaxing as it can be, was my hope. So let's move on. So the objectives for today would be to review the normal physiology of ventricular filling and diastole and sort of different steps on what happens and different Doppler signals and different things that we're looking for to constitute normal diastole. And as I said before, we're going to look at some of the different echocardiographic parameters that gives clue as to what the diastolic function of the LV might be. And once we identify diastolic dysfunction, being able to classify different stages of diastolic dysfunction. There's stage 1, 2, and 3, as we'll discuss later on. And we'll review the latest 2016 guideline, the ASE and EACVI, both endorsed on the Diastology, as well as potential caveats and pitfalls of the said methodology. So I'm just going to go ahead and say there's a spoiler, and there's a very neat diagram that you can look at the 2016 guideline. And this is sort of what I looked at initially when I was starting to sort of do some echo reading, is going through this flow sheet. You know, if someone has a normal EF or someone has depressed EF or has diastolic dysfunction, I would follow this diagram flow sheet, and it really lays out nicely as to how you can classify different diastolic dysfunction. But a question came to my mind is a lot of these numbers and parameters sounded very random. And as long as I don't have a great understanding of what's happening underneath, they're just going to be an extra thing to memorize rather than actually fully understanding what's happening. And I found diastology to be one of the less intuitive things, say, in echocardiography, along with regurgitant PISA and vena contracta and flow of convergence, those kind of things. So which sort of prompted me to look a little bit more into it. So I mean, we're going to get to this diagram, but hopefully the focus of today's talk is, before getting to this, where all these parameters came from and why these numbers exist and what they mean, what they're supposed to mean, is sort of the primary talk for today. And of course, it's going to be a little bit of an introduction for some of my fellow C1 residents as well, who will be doing echocardiogram rotation very soon. So what defines the diastolic function? So diastole, with this fancy Greek word, basically means to draw apart, as in something that is dilating or relaxing. So as you know, it's basically about left ventricular relaxation and elevated filling pressure if there is any diastolic dysfunction. And one of the definitions I was able to look at that sort of summarized it nicely was the inability of the left ventricle to fill normally at a normal left ventricular filling pressure. Another way they described it was having to have an elevated ventricular filling pressure in order to reach a normal diastolic volume. And there are a little bit more nuance to the diastolic function and different things that affect the diastolic function rather than just relaxation and filling pressure, which we'll get into in just a little bit. And diastolic dysfunction, as you all know, is quite important in just clinical practice as well. It's not just systolic dysfunction, it's systolic heart failure that we see in our clinical practice. And as well, we sort of abandoned the word of systolic heart failure and diastolic heart failure, because systolic heart failure also has an element of diastolic dysfunction as well. And people with more severe diastolic dysfunction definitely have worse prognosis, as found by the studies. And the classic diastolic dysfunction we usually think about are people with really thick ventricles with concentric hypertrophy, with small LV cavity, who are not able to fill adequately during diastole and therefore have low stroke volume. And a lot of factors can go into that, not just the primary myocardial diseases in terms of infiltrative and hypertrophic cardiomyopathy, like amyloid, for example, is something that we commonly see, but also secondary causes of hypertrophy like hypertension, aortic stenosis, certainly causes quite significant diastolic dysfunction as well. Coronary artery disease, both acute infarct and sort of ischemic heart disease, can also cause diastolic dysfunction as well. Something we often forget about is some of the extrinsic factor, not just something in the myocardium, so things like pericardial diseases. Not only that, things like RV volume, pleural pressure, sort of sort of a mass effect from outside tumors. A lot of those extrinsic factors can definitely cause a lot of these diastolic measurements to be abnormal as well. So, sort of like how I first learned ECG, before we go into the needy and wonderful details about abnormal diastolic dysfunction, we need to know what normal looks like so that we're able to identify what abnormal diastolic function is. And for that, let's just go over and take us back to medical school and go through the normal phases of diastole. So here we see the pressure curve for the LV, LA. And as you know, at the beginning, we have the end of systole. And at the end of systole, we have the closure of the aortic valve. And then we have something called isovolumetric relaxation, where the mitral valve hasn't opened yet. The LV pressure is high and it's relaxing. And as per the relationship between the pressure and volume and well, it's isovolumetric, but basically the pressure falls quite rapidly because of the relaxation that happens. And then when the LV, and that's the initial part that's highlighted in red here. So you have the isovolumetric relaxation that causes the rapid decline in LV pressure. When it reaches the level of LA pressure, and LA pressure actually becomes higher than the LV pressure, that's when the mitral valve opens and you have the inflow from the left atrium into the left ventricle. So that's called the rapid early diastolic filling, where there's a rapid blood flow from the left atrium ventricle. And this is more of a passive filling based on the pressure gradient. And this is sometimes what we hear as S3 after the end of systole. After that rapid period of diastolic filling in early diastole, the pressure between the left atrium and left ventricle sort of equalizes almost, and that we have minimal blood flow between the left atrium and left ventricle. And this period is called diastasis. And this is the one that gets quite shortened if someone were to become tachycardic. And at the end of diastole, we have the late diastolic filling. And the late diastolic filling is mostly driven, it's more of an active filling, mostly driven by atrial kick, an atrial contraction. As you can see on the surface ECG, you have a P wave and the atrial deprioritization as well. So you have an extra kick that heightens the LA pressure. So now you have that LA and LV pressure gradient again. So you have a bit of a flow at the end of diastole, though most of the filling has occurred in the early diastole. You have a little bit at the end as well. And then you have the end of diastole and your systole starts and the whole process repeats. And the reason why we need to know about normal sort of a diastole is then we can also understand what's happening with all of these echocardiographic parameters. So a lot of the things that I was just talking about was focusing on the pressure gradient difference between the LA and LV. And what is in between is the mitral valve. So this is one of the first things that people looked at is sort of how can we characterize the blood flow from the LA into the LV? So they looked at the diastolic mitral inflow pattern. And then as we went on, there's a few other things that we're looking at. So we can look at tissue Doppler imaging and pulmonary vein signal. And there are many others, but I will firstly go over these three main Doppler signals. Especially it could be quite confusing if it's the first rotation in echocardiography. So mitral inflow pattern, what we do is we put a PW Doppler pulse wave at the mitral valve leaflet tip during diastole. And it sort of measures the velocity at that location during that throughout the diastole. And what we have on the right side, we have a really nice sort of a pressure loop as well as the inflow diagram at the bottom. And the pressure, this is sort of the zoomed in version of the pressure curve we saw earlier. Here we have the left ventricle and the left atrium. And what we see is that the initial part, you have the isovolumetric relaxation with the LV pressure falling really rapidly. And when they reverse, as we said, the LA pressure is higher than the LV pressure. So you have the inflow of blood from LA into the LV. And that pressure difference at the initial early diastole is what causes the E wave for early diastolic filling. So we have the E wave, as I labeled here, and we have the diastasis, where there's not too much of a blood flow. So the blood flow actually sort of stabilizes in between. Now, here I haven't labeled DT. It's also called a deceleration time. You can think of it as a slope as well. And it sort of tells you how rapidly that flow sort of disappears as well. In the normal person, the E is quite big because, as I said, most of the filling happens in early diastole. And it also disappears quick. So you're going to expect a high E wave like this with a rapid slope or a short deceleration time, followed by a period of nothing. And at the end of diastole, you have an A wave from the atrial kick that I was talking about, from the atrial systole. This is the end diastolic filling from the atrial kick. But as I said before, this is not as significant as the passive filling that happened earlier in the rapid early diastolic filling phase. So you have a second bump called A wave that is a little bit smaller than the E wave that happened earlier. And this is how the normal mitral inflow pattern looks. And this is how it looks in real life. So you have the pulse wave sort of cursor at the mitral valve leaflet, and you see on multiple beats, the first, and you can also correlate it with the ECG at the bottom, and you can see that it happens in the diastolic phase. The first peak is the E wave as labeled here, and the second peak is the A wave as labeled here. So in normal mitral flow inflow pattern, you have the high E wave velocity, the steep deceleration slope or short deceleration time, and a bit of a lower A wave velocity. So if you calculate E to A ratio, it's going to be a little bit on the. It's not going to be low. It's going to be it's going to be in the intermediate range between 0.8 and 1.5. And as I'm going to go into later on, E to A ratio is something that we often look at just to see the relationship between the E and A ratio, and it sort of gives us a clue as to the filling pattern that we're going to talk about later on. Just as a caveat, the isovolumetric relaxation, there's also a measurement called IVRT. It just basically measures how long the IVRT is. In a normal person, it's relatively short because your ventricle is able to dilate quite quickly and drops the LV pressure really quick. So it should be less than 70 milliseconds. We don't routinely do this nowadays because it's not as accurate as some of the other ones, but we basically put the TW pulse wave Doppler in between the mitral valve and the LVOT, sort of in between enough apical 5 chamber view. Basically, you're trying to catch a glimpse of the aortic outflow as well as the mitral inflow, and the little period of pause in between is the IVRT, basically, and that should be very short in a normal person. And then we get to a fascinating tissue Doppler. So we're sort of applying the same Doppler principle, but we're sort of applying it to the tissue. So as you can see here, imagine this yellow dot. In a normal heart, this yellow dot would be moving up and down quite extensively. The excursion would be quite great. In an impaired relaxation, it's going to be a little bit less. So this is a glimpse of what the tissue Doppler would look like and where it labels E prime. And it's going to be negative because on the relaxation, it's going away from the probe. In a normal heart, the relaxation, the E prime wave would be higher than in impaired relaxation. So E prime gives us a clue as to the diastolic dysfunction as well. It basically in diastole, your LV is going to expand and lengthen. It basically calculates the velocity of the lengthening, of the longitudinal lengthening of the LV. So this is how it looks. We usually measure it at the lateral and the septal at the mitral valve annulus. And we often look at the E prime. That's the most important. And I highlighted in blue whatever I think is the more important value to remember. So E prime is going to be higher than the A prime, sort of a similar principle as what we were talking about before with the E wave and the A wave on the mitral valve inflow. And E prime on echocardiography sort of correlates to tau when we're doing the invasive measurement during cath measurements with the LV relaxation. It's sort of a non-invasive way to sort of estimate the LV relaxation time constant. And because the free wall is able to move more than the septal wall, we often expect the lateral E prime to be higher than the septal E prime. You also have the A prime, which should be lower than the E prime. You have the S prime, which is more so systolic, what happens during systole, so we don't really look at that during for diastolic dysfunction. So now that we look at the E prime, we have the E wave from before, we can take a ratio of E to E prime, and this gives us an estimation of the LV-BP or LV filling pressure. In normal people, I said E is high, E prime is also high, so the ratio itself is going to be less than 8 is what normally is. It's not going to be super high. The last thing we look at, and this is not necessary to diagnose diastolic dysfunction, it's also helpful to look at though, would be pulmonary vein Doppler. So we basically put the PW signal at the pulmonary veins, And you're going to see three waves. You're going to see an S wave during ventricular systole, D wave during the ventricular diastole, and that happens during the E wave because it's during the diastole. And then you're going to have the A reversal at the end, which is often a little bit difficult to see, and it's a lot more visible during the transesophageal as well. And the only thing to take away from this easy would be sort of an S wave is higher than the D wave usually. Sometimes they're sort of equivalent, but definitely D wave should not be higher than the S wave on a normal sort of normal heart is what we expect. So now that we sort of talked about what normal should look like, what does diastolic dysfunction look like? And I said that I'm going to go back to defining what diastolic function is and what sort of determines diastolic function. So we talked about LV relaxation, and sort of a relaxation and compliance, as I came to find out, is sort of a bit of a different sort of a principle. So relaxation is just the actual process that actually expends energy, and the myocardium is actively going under that process of relaxing. It occurs during the early diastole, including the isovolumetric relaxation. It has more to do with the pressure, so it's actually a negative DT, but it has to do with the pressure difference over time. And that's what the tau measurement is also sort of looking at as well. Compliance and stiffness, which are inversely related, is sort of more so looking at the intrinsic factor of the myocardium and the chamber, which also depends on the shape of the myocardium, etc. This one basically is more so the pressure and volume curve relationship with the smaller change in volume, there's a higher pressure difference. And the last thing that's going to sort of impact our measurements would be the diastolic filling pressures. Now, keeping these parameters in mind, we can go ahead and see how things change in terms of diastolic dysfunction. So in the past, it used to be 4 different grades. So grade 1 would be impaired relaxation, so the initial part that I was talking about. Grade 2, as your compliance gets worse, you would actually have pseudo-normalization of the mitral inflow pattern. It's not actually normal, but it looks normal. Grade 3 would, again, look abnormal, and you would have restrictive filling. And grade 4 used to be irreversible restrictive filling, but on the most recent guideline, they actually combined grade 1A into grade 2. So grade 1 would be normal filling pressure, and grade 2 would have the increased filling pressure. And grade 4 was just bunched together with grade 3. So it was just combined restrictive filling nowadays. So now we have more simple grade 1, 2, 3 grading. And we're going to go through how that looks in terms of the parameters that we were talking about. So here is normal, just a quick recap. So we have the mitral inflow signal here. As I said, the early diastolic filling is rapid, so you have the high E wave. You have the late diastolic filling by the atrial kick, which is a little bit less than the early diastolic filling. So you have the high E wave, low A wave. So the E to A ratio is going to be on the higher side, 0.8 to 1.5. It's not going to be super high, but it's going to be higher than early diastolic dysfunction. It's going to be in this range. If you look at the tissue Doppler, we mostly look at the E prime, as I said. So E prime is going to be normal, and it's going to be high. So E to E prime ratio is not going to be high because your E prime is not going to be low. It's at the denominator. So you have to sort of inversely think about it. If you look at the pulmonary vein Doppler signal, as I said, the S wave and the D wave, S wave is usually higher than D wave, or they're sort of on a almost equivalent, but D wave should not be higher than the S wave. This is how normal looks like. Now that we know how normal looks like, what happens if you start to have some diastolic dysfunction? So the early phase of diastolic dysfunction is characterized by impaired relaxation. And that we're mostly talking about the isovolumetric relaxation time, as well as the early diastolic filling phase. So as I said, the relaxation is at that beginning part of the diastole, and your myocardium's actively trying to relax, and this is impaired. So as you can imagine, if your LV is taking longer to relax and that's impaired, your isovolumetric relaxation time is going to be prolonged because it just takes longer for it to relax. The drop of the LV pressure during the IVR is going to be a little bit less rapid. So you're going to have reduced slope of dP over dt. So your IVRT is going to be longer. And because of that, your LA and LV pressure gradient, once the mitral valve opens up, because of the impaired relaxation, is going to be lower. It's supposed to have very higher LA pressure in the LA, lower LV pressure in the LV as the LV relaxes, but because of the impaired relaxation, your LV pressure doesn't go down as much. So the pressure gradient is lower. So that the pressure gradient that drives the initial E wave is not as high as expected. So you're going to have reduced E wave at the beginning of early diastole, which is supposed to be high. To compensate for that, the late diastolic A wave is higher as you're not able to push more blood during the early phase. So now you have more preload in the atrium. So your atrial kick pushes more of that blood into the left ventricle at the end of diastole. So you have what we have, the reversal of the E wave and the A wave in the impaired relaxation phase of this diastolic dysfunction. So you have E to A ratio that is actually lower than 0.8. Before it was higher than 0.8, now it's lower. E is actually lower than 8. Some of the other things that we can look at is, as I said, IVRT is a little bit more prolonged. Because the E wave is smaller, the deceleration time is going to be prolonged and less steep, as you see here, compared to before. But E to A ratio is the most important thing we can probably look at here. And this is how it looks in real life. Compare this to the old one where the E wave was higher and the A wave was smaller. Now you have the reversal of the E and A wave. And if you look at the tissue Doppler, it's sort of a similar idea. So your E prime becomes low. And that's going to be sort of an underlying theme going forward in diastolic dysfunction is that your E prime is going to be low because of the impaired relaxation. Your velocity of the tissue as it relaxes is going to be on the lower side. Similar principle as before as I was talking about. And it's going to be actually lower than the A prime wave at the end of diastole. So if E is low and E prime is low, they've sort of both gone down at the same time. So your E to E prime ratio is going to remain low. It's not going to be super high. So things to remember, E wave is low, E prime is low, E to E prime ratio is going to be low. And if you look at the pulmonary vein signal, your D wave is going to be reduced only because during your E wave, your LV filling is reduced. So you have less of a flow from the pulmonary vein into the left atrium because less emptying from the left atrium is sort of backs up basically. So to compensate for that, your systolic pulmonary vein draining is higher. So your systolic wave compared to diastolic wave is going to be higher. So it shouldn't look too different. I mean, S was higher than before. Now it looks even higher, but it's not reversed or anything like that. If that were to continue, so before it was just impaired relaxation, if you were to have continued diastolic dysfunction and you have now worsening compliance, which is a bit of a different sort of a concept than just impaired relaxation. Now you have worsening compliance and you have worsening compliance of the chambers and you have now elevated LA pressure, as I said. Increase in LV, the left side of pressure now goes into grade 2 diastolic dysfunction. Once you have elevated LA pressure, now the story is different because the LA and LV pressure gradient we were talking about before that sort of lessened because of decreased E wave is now normalized. Now LA pressure is high again. So now you have high LA and LV pressure gradient again. So what you have is what we call pseudo-normalization. You're still going to have, again, back into this really high E wave. Now that your LA pressure is really high, it can push blood into the LV. Because of the diastolic dysfunction, the LA pressure is high. So your initial E wave is now higher than the late diastolic A wave again. But you have diastolic dysfunction, so this is not supposed to be normal. It just looks normal on a mitral inflow. Your IVRT is again going to be shorter for the same principle. Your EA ratio is high again. However, if you do the tissue Doppler, because you still have diastolic dysfunction, is one of the ways to differentiate between normal and abnormal, your E prime is going to remain low. So the E to E prime ratio that we were talking about before, now it's going to be higher than before. It can still be within the normal range, but it's going to be higher than before. So your E is higher, E prime is lower. So the ratio of the two is going to be higher than grade 1 diastolic dysfunction. And this is how it looks on a real life. So you have a normalization of the E wave. It's now higher than the A wave. Sometimes you see something called an L wave in between, and that's because your LV relaxation is markedly prolonged, that in mid-diastole, you still have relaxation of the left ventricle. So you have another moment where your LV pressure drops compared to the LA, and there's a third, like a mid-diastolic wave from the LA into the LV. So this can be quite specific for diastolic dysfunction in the context of myocardial disease. Can sometimes happen in bradycardia in like young healthy people as well, but quite rarely as well. One way to differentiate pseudo-normalization from actual normal, other than the E prime, would be getting people to do Valsalva maneuver. So if you can imagine, the problem with pseudo-normalization, why this happens in the first place, is because your LA pressure is high. So if you can decrease preload into the LA, if you can decrease how much stretch there is in the LA by decreasing the blood flow, for example, through Valsalva, you're decreasing the preload into the left atrium. Then you unmask and reveal grade 1 dysfunction. Now your LA pressure isn't that high because of the decreased preload. So when you do Valsalva, as you can see in this example, your E and A relationship is going to flip when your preload decreases because your LA pressure is now dropped. And a formal way to sort of say this is that your E to A ratio, which used to be high, is now dropped. And the 50% decrease is what we say in terms of sort of a decrease in E to A ratio caused by Valsalva maneuver. This is yet another way to differentiate. The last way to differentiate would be looking at your pulmonary vein signal. As I said, the S wave, D wave should not be higher than the S wave, but here S wave is markedly reduced because during systole, when the pulmonary vein is supposed to drain into the left atrium, your LA pressure is high already. So there's not going to be as much draining into your left atrium during systole, where most of the draining is supposed to happen. So to compensate, you have a predominant D wave now. So you have a reversal. Now the D wave is higher than the S wave on the pulmonary vein. The last thing I'm not going to spend much time on, the AR to A duration, because AR signal is very hard to see on a transthoracic echocardiogram. But basically, your AR is going to be a little hump at the end here, the reversal signal, and it's good. The difference between the AR duration and the A duration from earlier is going to be high because your A duration gets short. Because your A duration gets short because of your LV, sort of a high LV pressure, LV EVP. So your atrial kick and then normalization after that atrial kick is going to be super fast because your LV pressure is already high. So A duration is very short, so AR minus A is going to be high. I haven't really looked at that calculation, to be very honest. And sort of the severe diastolic dysfunction would be restrictive filling. And if you have continued worsening of the compliance, and if you have continued worsening of the pressure, you have sort of this of a pattern where your E wave is going to be very, very high. And that is because you have marked increase in early mitral inflow. Again, because of the very high LA pressure, your LA and LV pressure gradient is going to be very high. So your mitral inflow is going to be super high. So your E wave is much higher than even what we normally expect. And your A wave is going to be low. So in this case, and the slope, the deceleration slope is going to be very steep. In this case, E to A ratio is going to be very high. In fact, there's a number that we look at. E to A ratio is going to be over 2 because LV pressure is so high that it's driving such a high E wave. Again, similar principle. E prime is going to remain low as long as there's a diastolic dysfunction. So if E wave is very high and E prime is very low, your E to E prime ratio, which gives an estimate of the filling pressure, is going to be very high. And the number we can often look at is 14, E to E prime ratio. And this number can change based on septal E prime and lateral E prime, but we often take the average of the two. As I said, lateral E prime is supposed to be higher than the septal E prime. The pulmonary vein signal is still going to show D over S predominance, and the AR is going to be a little more predominant as well. Some of the other echocardiographic parameters that we're supposed to look at would be things that are a little bit easier to understand. So things like LA volume. So the volume index of 34 is sort of the cutoff. And this can be indicative of sort of a long-term elevation of the LA pressure. As you can imagine, with the high pressure, your LA sort of undergoes sort of a dilatation to accommodate for the high pressure. And it can give us a clue that, oh, there is actually a high pressure thing going on with the diastolic dysfunction, with caveat, obviously. TR jet we can also look at, and it should be greater than 2.8 meters per second. And TR-jet, if you use modified Bernoulli's equation, can estimate pulmonary arterial pressure, specifically PASP, which should be sort of a continuous in terms of the pressure with the left atrium, as long as there's nothing in between that causes your pulmonary pressure to go high. For example, if there's no COPD or any pulmonary disease, for example, if there's a very clean sort of a continuous pathway between the left atrium and your pulmonary artery, then you can look at your TR-jet velocity to estimate your pulmonary artery pressure, which would estimate your LA pressure. And if it can give you that if TR-jet is high in the absence of pulmonary disease, then your left atrial pressure is probably high. There's sort of similar principle for assessing mitral stenosis as well. And there are many other parameters that I did not talk about today, and I'm gonna not so much talk about that today because it just will go on forever. This is an example. So if I go back, this is left atrium on the apical fourth chamber. As you can see, this is super dilated. It's supposed to be like about yay big, about a third, but it's definitely much dilated. This is a TR signal with a CW wave Doppler. And you can see that this peak velocity is definitely over at least 3 meters per second here. It actually labels the gradient, but if you put a dot there, the peak velocity, jet velocity is going to be definitely over at least 3 meters per second. So that's what it's sort of looking at. This is a summary. Again, it's going to be super hard to memorize, and I definitely haven't memorized this at all. But it's if you go through step by step of what I sort of explained in terms of grade 1 to 3 diastolic dysfunction, you can make rationale as to why your E and A wave sort of flips and then flips back. So in grade 1, it flips, and then in grade 2 and 3, it flips back with high E wave with the elevated LA pressure. And you can sort of look at things, and your E prime, as I said, is going to be low as soon as you have diastolic dysfunction. And you can look at some of the adjuncts in terms of pulmonary vein, Doppler signal, IVRT. You can look at other things like LA volume, as I said, TR-jet. But this sort of gives us a nice summary as to all the parameters of diastology, which is pretty neat. That was a lot to talk about, and definitely don't have it memorized. So what is an actual practical approach that we should do in real life? Well, let's go to 2016 ASC and EACVI Guideline. There was a 2009 one which talked about a lot of those. And as per the guideline in 2016, they say that it was too complex, too complicated. A lot of readers thought that you have to satisfy every single one of those criteria, when in fact, diastology isn't really dependent on one number, because a lot of those different numbers can depend a lot on extrinsic circumstances, such as preload, heart rate, extrinsic pressure, a lot of valve disease, heart rhythm. A lot of those things can affect your E prime measurement, E wave, A wave, etc. So you can't really look at one number to assess diastolic function, which is why you have to look at multitudes and sort of make a call based on how many of them you satisfy in terms of potential diastolic dysfunction. So 2016 guideline came out to sort of simplify that, and they have a very neat diagram that I showed earlier. So in someone with normal EF, so let's say someone has hypertrophic cardiomyopathy, their EF is over 55%. You look at 4 things, and 4 things only, to sort of go through this pathway. First would be average E to E prime ratio. If you remember back, in severe diastolic dysfunction, your E should be very high and your E prime should be low because of diastolic dysfunction. So E over E prime is going to be very high, and 14 is the cutoff. So that's what number 1 is looking at. Number 2 looks at basically your E prime velocity. It should be low in diastolic dysfunction. Exactly what it's saying here. Your septal velocity is a little bit lower because your septum moves a little bit less than the lateral left ventricular free wall. And adjuncts that we look at, TR velocity, as I said, gives an estimate of LA pressure in the absence of pulmonary disease, and LA volume can give us a clue as to chronic elevated left-sided pressure. And you look at 4 of them, and if you have less than half of them positive, so if you have 1 positive, let's say their TR velocity is very high, but everything else is fine, you have a normal diastolic dysfunction or normal diastolic function, move on. If you have 3 of them or 4 of them positive, then you definitely met so many criteria, and you definitely met one of these for sure, the Dopplers I was talking about, then you have diastolic dysfunction, and you move on to classifying what kind of diastolic dysfunction it is. It gets a little bit tricky in the middle where you have only 2 of them positive. It becomes indeterminate. I'm sure there's a lot of debate as to what to do with these people. We just report them as indeterminate diastolic dysfunction, but a lot of people have different opinions about what to do in these kind of scenarios. Now, if you have diastolic dysfunction because you satisfy a lot of these criteria, then you can classify what kind of diastolic dysfunction you have based on, before you were looking at mostly E prime and E over E prime. Then your next step would be looking at E over A. If you remember, E over A mostly looks at the mitral inflow signal, comparing the E wave and the A wave. And going back here, it's basically looking at, I don't know if you can see my mouse, but it's basically looking at the top row. What's the relationship between E wave and the A wave is basically what it's talking about, because you can flip back and forth and have different numbers based on the degree of diastolic dysfunction, as I explained earlier. So your E to A ratio is low, and your E wave is not that high, and it's not that high because your LA pressure is not high, and your E to A ratio is low, then you only have grade 1 diastolic dysfunction, and you have normal left atrial pressure. If your E to A, I'm going to skip this for a little bit. If your E to A ratio is in between, then you're going to have to go through this whole thing. Well, let's skip that for a second. If you look at the far right, E to A ratio over 2 is a very high ratio. If you can remember, grade 3 diastolic dysfunction has a very high E wave and a very low A wave, and the cutoff for the ratio is 2. That automatically qualifies you for grade 3 diastolic dysfunction with elevated LA pressure. Now, the difficulty comes when it comes to the E to A ratio in between that intermediate range. Then you look at, again, some of the other adjuncts. So the same principle with the E to E prime ratio over 14, which gives us a clue as to the elevated LVEDP. TR velocity and LA volume can give us a clue as to the elevated LA pressure. And we do the same thing where if you have the majority positive, you have higher grading. If you have majority negative, you have lower grading. And you have 1 positive and 1 negative, then you're sort of in the middle, where, again, we're sort of an indeterminate range. You can use some of the other adjuncts. So you can perhaps look at pulmonary vein. Sort of, you're supposed to have a flipped D to S, starting from grade 2 diastolic dysfunction. So maybe you can look at that. You can look at some of those adjuncts to sort of classify different diastolic dysfunction. So this really lays out nicely. And also, something I forgot to mention is you go to this diagram when you have a known diastolic dysfunction, but you also go straight to this diagram if you have decreased LVEF, because systolic dysfunction is oftentimes associated with diastolic dysfunction, and if you have a known myocardial disease. So earlier, I should not have said a known hypertrophic cardiomyopathy as an example. So if you have a myocardial disease, known myocardial disease, then you should go straight into this diagram because they are expected to have abnormal E prime and abnormal diastolic dysfunction. So you have to classify what kind of diastolic dysfunction it is. So that was the sort of a practical way to go through the diastolic dysfunction without having to go through the mental gymnastics every time we read through an echocardiogram. Some of the caveats that I quickly want to mention, obviously, I don't want to go too much depth into this because it's a whole new deal as well. The ideal scenario of, normal grade 1, grade 2, grade 3 diastolic dysfunction, the natural progression is obviously an ideal progression. You can have sort of an exception. As I said, a lot of those measurements are dictated by sort of surrounding hemodynamics and surrounding extrinsic factors and intrinsic factors. Some of the common ones I've listed here. So in atrial fibrillation, your atrium's fibrillating, so you don't really have an atrial kick. So you have no A wave. That's not what is showing here, but you have no A wave, so you have an E wave, but you don't really have an A wave to work with in terms of E to A ratio and whatnot. You also have irregular heartbeat, so you're going to have variable cycle length, which means that you're going to have variable preload. And with atrial fibrillation, you're going to have most of the time you're going to have left atrial enlargement as well because of the heart rhythm problem as well, not just from diastolic dysfunction. So because of a lot of these factors, you can measure, E over E prime over multiple RR intervals, and you take multiple cardiac cycles and multiple beats and average it out. You could do that. You can, because you only have an E wave, you can take a look at the deceleration time, and that is a possibility. But oftentimes we say that diastolic dysfunction cannot be determined because of atrial fibrillation. It's sort of and this is sort of as a sort of an important sort of a fun tidbit, because you don't have an A wave, obviously you're not going to have the S4 on auscultation with the atrial kick. Fun sort of a anecdote that I had on CCU when I was an internal medicine resident is we had someone with paroxysmal AFib who was chronically paced, but their fibrillatory wave was very low volume, low amplitude. Their P wave when they're in sinus was also very low amplitude. So they're paced. We're not sure if they're in AFib or not because their baseline just looks very flat. I don't know about Lewis configuration or anything like that to accentuate P wave. We went to the echo lab and we basically looked at whether there's an A wave or not, and there was no A wave. So we said, oh, this is basically atrial fibrillation then. Anyhow, in case of mitral valve disease, so if you have, for example, mitral stenosis or severe mitral regurgitation, in mitral stenosis, you're going to have exceedingly high E wave because of the natural pressure difference. In severe MR, because of obviously the narrowing of the valve, in severe MR, you're going to have a lot of backflow into the left atrium. So your left atrial pressure is going to be high from so much, regurgitant volume going into the left atrium. So your E wave is going to be misleadingly high in these mitral valve diseases, which can be a problem in trying to, assess these E to A ratio and E to E prime ratios as well. Sometimes you have something called E to A wave fusion, and this is what I'm showing here at the top. You can have multitudes of rhythm disorders and mitral valve disease that can cause this. If you remember earlier, in tachycardia, diastasis in between the E wave and the A wave is the one to go first. You know that in tachycardia, diastole is the one to go first, and in diastole, it's diastasis that goes first. So what happens is that your E wave and the A wave comes very close, and if the tachycardia becomes severe enough, they actually sort of fuse. Here you can at least tell on the right two beats that E wave and the A wave you can a little bit tell. On the first two beats, you cannot really tell where the E wave ends and where the A wave begins. That would be hard to sort of assess diastolic function in that case. First degree AV block, because your E wave comes too late, can also cause E to A wave fusion. In mitral valve disease, like mitral stenosis, can also cause fusion of the E to A wave. And you can't measure things like deceleration slope in those cases. And again, lastly, if you have severe MAC, with a severe calcification, your movement of the mitral annulus is going to be very severely limited, not because of the diastolic dysfunction necessarily, but because of just the mechanical cause of severe calcification. So your E prime is going to be very low from mitral annular calcification as well. And your E to E prime ratio might be misleadingly high because of that as well, and not because of, again, not because of diastolic dysfunction, but because of the mechanical causes. And there's a whole, and if you look at the 2016 guideline, they actually have different ways, and they also talk about hypertrophic cardiomyopathy, infiltrated cardiomyopathy, and how to measure diastolic function in those specific cases. But I am also running out of time, and that would be going into too much detail and a lot of overload. So with that, I'm going to end the presentation on the basics of Diastology, and this was very fun and helpful for me to sort of learn about, to try to learn about what those Doppler signals actually mean and how they change with the hemodynamics. So thank you for listening for this long talk, and I'll be open for any questions.
So thank you, Daniel, for this very comprehensive review. It's always a very difficult presentation to give, and thanks for explaining all the little symbols that we use on a daily basis. So let's see if any one of my colleagues have any questions. Maybe I'll make a comment about the indeterminate one. That's the difficult one. Daniel, can you go back to the slide where it's the step number 1 of the assessment? Oh, there. Yep. So one of the challenges that often we face, and when we talk to even experts and colleagues who put this paper together, it's the middle group. So I think on a day-to-day basis, if you find normal diastolic function, you can leave it there. If it's diastolic, dysfunction, you often go to the next one to grade on whether it's 1, 2, or 3, and also you have abnormal LVEF, then you go to the next diagram. That's routinely what we do. The challenge is what to do with the middle. So let's say if you have someone who comes in with a TRJ that is more than 2.8 or LV volume index more than 34, so then like you're in the middle of that. Or you have more commonly you have LV volume index more than 34, where it's like 35, 37, 38, somewhere around there. And then you have the septal E velocity are low, and then it's one of the two, or lateral E velocity is low, then you fall in the indeterminate. So one of the options is to leave it there, and we have done that before, and ends up actually when people do that way, I think study have shown that we end up having around 30 or 40% of patients on a day-to-day basis may have just indeterminate. So then some of the proposal is actually take the indeterminate one and actually go into the second table, which is the next one. So that's another way to look at it. So let's see what our colleagues have said, because I think in the cardiology community, people have done one of the two approaches. If you just leave everyone in the indeterminate, then actually quite a number of your reports is going to be indeterminate diastolic dysfunction, and then like now the question is, so what? Or you can take another step to go into this. So let's see what my colleagues have to say about this. So Howard or Kim, if you're on, or Geraldine, what do you think? Let's see if I can bring them online.
Chiming,
yes.
When you say bring it into the flow diagram that's shown here,
right?
Do you mean consider it as somebody with LV systolic dysfunction or myocardial disease, and then try and differentiate further based on this second algorithm? Is that what you mean?
Yes. So some people do that, and when you talk to some of the colleagues who actually wrote this paper, and they do that too. So that's not well spelled out in terms of how to deal with the indeterminate.
Yeah. So I guess two comments. One is that I think you're going to have some patients where you're going to end up calling grade 1 diastolic dysfunction and probably doesn't make a huge difference clinically, because grade 1 just means that there's impaired relaxation, but there's no increase in filling pressures. So the difference between grade 1 and normal diastolic function really is somewhat arbitrary, right?
Yep.
So but then you're labeling them with some degree of abnormality, which was the major controversy before, where you'd have an 89-year-old patient with grade 1 diastolic dysfunction, impaired relaxation, and whether or not that is normal for them, the normal aging process versus something pathological. I think that's the challenge. So I don't do that. I don't put it into the second algorithm, but I can see why others would be doing that. I'm going to add one more point, is that I do agree with you. I think the indeterminate is potentially an issue, and I think there are. You probably know about some of these studies, Chiming, but there are studies that look at artificial intelligence means to try and differentiate further, bringing in a few other different echo parameters to determine the presence of diastolic dysfunction and grading it. That's a little bit more nuanced, but because you use AI technology, it's just a matter of collecting the parameters, feed it into an algorithm, and then it'll give you a bit more discriminatory data. And in part because I think some of the parameters have a little bit more weight with regards to diastolic dysfunction versus other parameters.
Yeah, that's Dr. Pavosam Gupta making his career on this one, in terms of looking at multiple parameters in diastolic dysfunction and some clinical data as well. Okay, so
There is a new study that came out of Mayo Clinic in the last 2 months. I don't really recall the details, but they used two parameters of left atrial strain. I think it was called reservoir strain and pump strain of the left atrium, which apparently seems to have some correlation with invasive left atrial pressure. So that could be a potential kind of emerging new tool that we might use in the future that could help differentiate.
Yep. The LA strain is a big topic. I think it's not in the guideline yet. We recently had a journal club on this one at the Canadian Society Echo, and it is showing some promise, but not all our machines can do it at this point.
It's Bob. Just following up on Howard's comment. Is it not, Howard, the E over E prime greater than 14 is the one that a number of folks, I think, are focusing on? I mean, it's, you know, there's lots of reasons for the LA volume to be increased or the TR velocity to be increased, but the E over E prime seems to be the one. If that's abnormal, regardless of LV systolic function, that's what's pushing people to say there's something wrong here. You know, this isn't normal, right? It's weighted on that one. Is that right?
Yeah, so I think I do agree with you. I think you know, the E over E prime, I think, has always sort of anchored the diastolic guidelines. I think in part because of Sharif Nagay, who kind of drove that. But I think most of us feel that, you know, if the E over E prime is abnormal, especially if it's very high, then I think we're more likely to think about diastolic dysfunction, high filling pressures. And for me personally, if it's driven more by a high mitral E velocity, I feel more comfortable. Sometimes I do wonder about super low E primes on tissue Doppler and what it truly reflects. If it's driven, let's say the E velocity is 50 centimeters per second, but the E prime is very, very low for whatever reason, then I'm not as sure.
I guess the reason for that is that looking at all the diastolic parameters, the E over E prime over 14 was the only one that was systematically associated with outcomes in different populations, AES, you know, cardiomyopathy, like different diseases. So I guess that's why this one stuck more, and it was easier to study it like as a number. And then that's why with the SAPIEN registry, when we actually studied the diastology using this, then having the combination as they suggested in this guideline was also associated with prognostic implications. And what's interesting also about the indeterminate is that when we plotted those guys in as well, they did in terms of prognostic worse than the grade ones. And there was really an incremental increase grade, and the intermediate was between the grade ones and the grade twos. So indeterminate is not normal. So then we can argue we just leave it indeterminate or just call it, you know, normal or abnormal. That's another way of thinking about it, I guess.
Geraldine, obviously there's a few different ways when you're in the normal EF pattern to get to indeterminate. And sometimes if it's the left atrial volume being dilated and either septal or lateral E prime being below 7 and 10 respectively, that indeterminate might be different than an indeterminate where the E over E prime is high and the RVSP is high, but left atrial volume is normal, and the septal and lateral E prime velocities are within normal. Do you know what I mean?
Yeah, so we actually, when we did that paper with in the SAPIEN registry, we spoke to JO about this exact thing, because people were arguing why there was no normal diastolic function in our cohort of disease patients. And he says, well, that's obviously a flaw of this diagram, right? So he seems to say that if you just have like a regular normal EF study with no other significant disease, then you know, if you have those, then it's indeterminate, it's indeterminate. But then if you have some sort of disease of some sort, if there's pathology on the echo of other, then, you know, then you use the other one. And if it's indeterminate, then it may not, you know. So it makes that there are a lot of indeterminate. And after that, when I look at it in the lab, I find myself putting a lot of indeterminate. I mean, like, and then there's always this thing: do you follow? Do you just say indeterminate, or do you kind of, you know, kind of blend it with the old guidelines and kind of, you know, because often if you bind it with the old guidelines, you'll end up what's indeterminate in this guideline, and if you use the other one, it would be grade 1. Have you noticed? It's very close.
I think what some of our readers do is that they'll say that it's by guidelines it's indeterminate diastolic function, but high E over E prime suggests high filling pressures.
Yeah, I guess that's a way to nuance it. But if you use the old guidelines, a lot of these indeterminate will end up grade 1.
Yeah, I agree.
And that's what we found also in the SAPIEN cohort.
But sorry, just to clarify, but shouldn't all TAVI patients be in the second algorithm with myocardial disease, given that?
Yeah, but a lot of them, like a third of them, end up in the indeterminate.
Sure.
Yeah, like a third. It's a lot. Right?
Well, that's one of the pitfalls of this particular guideline.
Yeah.
When you come up with it, they couldn't be sure, so they end up actually like putting this into this bin of indeterminate and become a two-stage process. So from an application point of view, it's still kind of complicated in that sense, although it's less complicated than the one before.
I guess it makes
way
sense.
better than the one before.
I guess it makes sense to say indeterminate with, and then comment on the filling pressures separately. I guess that kind of makes sense.
Okay, so with that in mind, I think it's 9:01. So I want to thank Daniel for putting in all this effort to try to explain all this to us one more time. And now we have it on the video so we can watch it again. And thank you for everyone for joining. And please tune in again next Thursday. And also these are available online for those people who couldn't make it during a particular time. So have a wonderful summer, and I'll talk to all of you soon. So take care, and we'll sign off now. Thank you, everyone.
Thanks, Jimin. Great job, Daniel. That was a great talk.
Thank you.
Okay, please do your evaluation.